In the rapidly growing field of equine dentistry, veterinarians can offer clients a high standard of care, including many surgical procedures that allow horses to live long lives with comfortable, functional mouths. The gold standard for equine cheek tooth extraction is to use an intraoral technique in a standing, sedated patient. Today, I'm going to go over a transbuccal technique for cheek tooth extraction that was developed by Dr. Manfred Stoll from Germany. I've performed this technique 3 times with my mother, Dr. Carol Akers, who learned it from Dr. Stoll and Dr. Frank Schollenberger, and the majority of my images are from these procedures. I will use cheek tooth 209 as the example tooth, since this was the affected tooth in 2 of my 3 patients. This technique can also be used on a mandibular tooth, but it's a little more difficult. Just to make sure everyone's on the same page, I'm going to quickly review the modified triadan numbering system that's used for dental charting. The mouth is divided into 4 quadrants as pictured here. The numbering starts with 100s in the right maxillary quadrant and continues around to 400 in the right mandibular quadrant. Unlike cats and dogs, horses cannot open their mouths very far. This means that many dental procedures, such as the extraction of a cheek tooth, are difficult due to lack of access. Teeth with sufficient crown can be extracted intraorally with extraction forceps, but often you have a tooth that needs to be removed that is fractured or damaged, so there's not enough purchase for extraction forceps. There also may be a root fragment that needs to be extracted, or there might be a developmental anomaly. Also, some horses just have too small an intraoral space and the instruments will not fit. You should note the branches of the facial nerve that cross the masseter muscle in the horse, because these will be very important later on. One solution when presented with a case where traditional intraoral extraction is impossible is to use a technique developed by the German veterinarian Dr. Manfred Stoll. A screw is inserted through the cheek into the affected tooth, and then the tooth is tapped out of the alveolus. This technique can be performed in a standing patient and requires only a small skin incision, resulting in excellent post-surgery cosmesis. This is a picture of Dr. Manfred Stoll teaching his technique at a lab. This is an example of a candidate for a minimally invasive cheek tooth extraction. You can see that cheek tooth 209 is diseased and needs to be removed, but there's not enough crown here to get good purchase with dental extractors. This is a radiograph of a horse with a fractured 209 that needs to be removed. The advantages of Dr. Stoll's technique over alternative techniques such as retropulsion or buccotomy include straight line access to the tooth, lower anesthetic risk to the patient, lower costs for the owner, and fewer complications. Since the technique only requires a 5mm skin incision, it has excellent post-operative cosmesis. And this is something that can be very important to owners, especially if the patient is a performance horse. The procedure requires the horse to be sedated and secured in a good set of stocks. Because the procedure can be prolonged, a CRI is an important part of the sedation protocol. You will also need a really bright light source, a padded headstand, a dental speculum that allows access to the side of the horse's face, gingival elevators, dental spreaders, and extraction forceps. For the actual extraction, you also need a special set of tools. Dr. Frank Schollenberger from Germany makes a specialized set, but all of these components could be made from things you can get at Home Depot. Here is Dr. Stoll using a Gunter speculum. As you can see, there's very little on the side of the horse's face here. And this is a stub speculum, which can be used in some cases, especially if you replace this with a bungee cord. The key to successful procedure is a careful patient preparation. The first thing to do is to shave and perform an initial scrub of the face ventral to the facial crest. Next, you sedate the horse and block the left infraorbital branch of the maxillary nerve using the extra periorbital fat body injection technique. This block will anesthetize the entire left maxillary quadrant. This is very important because you do not want the horse to feel the procedure. The block has a duration of 2 to 4 hours and requires about 15 to 30 minutes to take effect. This is why you should perform the block early in your patient preparation so that it has time to take full effect before you begin your procedure. Once you've blocked the maxillary nerve, it's very important to identify and mark all of the important structures that are near the surgical site so you can avoid them during your procedure. The extra periorbital fat body injection technique uses 6 to 10 cc's of carbocaine injected through a 22-gauge spinal needle placed just ventral to the zygomatic arch at the level of the caudal third of the eyeball and rostral to the rostral rim of the mandible. The needle should be advanced 30 to 35 millimeters through the masseter muscle and into the periorbital fat body. You'll feel a change in consistency as you advance into the fat. Advance a further 15 to 20 millimeters into the periorbital fat body, aspirate, and then inject your carbocaine. If you contact bone, you need to withdraw the needle a few millimeters before you inject. While the block is taking effect, you should identify and mark several important structures on your horse's face. There are 2 to 4 branches of the facial nerve that cross the masseter muscle in horses. There's also the parotid duct, facial artery, and facial vein that are all very close to where you need to make your incision. You should find these structures with digital palpation and then draw them on the patient's face with a permanent marker. An additional precaution is to use a size 8 polypropylene dog urinary catheter to catheterize the parotid duct, and this will make it easier to feel when you're getting ready to make your incision. It's very important to know all of these structures. The next step is to place skin staples at the apex and the occlusal surface of the affected tooth, and also at the occlusal surface of the opposing tooth. This is to help orient you and will aid in your incision site selection. You should take a radiograph to confirm you have placed them correctly. At this point, your nerve block should be in effect and your patient should be adequately sedated and you're ready to begin. The first step is to elevate the gingiva all around the affected tooth using a gingival elevator. Then you loosen the tooth as much as possible using dental spreaders. Dental spreaders come in graduated thicknesses. You start with the thinnest ones and place them between the teeth and slowly squeeze them closed. This action mechanically breaks down the periodontal ligaments that normally hold the tooth in place. Once you can completely close one set, you move to the next thickest. The looser you can get this tooth at this stage, the easier the extraction will be. You should always attempt oral extraction with dental extractors at this point. If that fails, then you move on to the minimally invasive transbuccal approach. The first thing to do is to identify the location of the affected tooth by placing your hand inside the mouth and feeling the tooth, and then pressing on the cheek from the inside while also feeling from the outside. Identify an incision site that avoids all the important structures that you previously marked and do a local skin block with lidocaine. You should then use a 22 gauge needle to check your proposed incision site. Place the needle through the cheek and look inside the mouth to make sure you're going to have access to the tooth that you want to extract. You then make a stab incision through the skin of the cheek and place a trocar through the trocar sleeve and bluntly force it through this cheek. There are blunt and sharp trocars as well as short and long ones. It's best to go through as much of the soft tissue as you can with a blunt trocar before switching to the sharp one to penetrate the tough buccal mucosa. Once you penetrate the buccal mucosa, you remove the trocar and leave just this metal sleeve, which will protect all your soft tissue structures from your extraction tools. The first extraction tool that you use is a dental luxator. This could also be a large flathead screwdriver from Home Depot. Insert the luxator through the sleeve and place it mesially and then distally to the affected tooth. You can tap gently on the end with a hammer to seat it more firmly between the teeth. Once it's seated, you use rotational pressure to break down the periodontal ligaments. This part requires patience, but it's very important to a successful extraction. You may need to hold twisting pressure for up to 5 minutes at a time to fatigue and break down the ligaments. This will further loosen the tooth. Once the tooth is as loose as possible, it's time to drill the hole. Always place a protective drill sleeve inside the trocar sleeve to prevent the drill from tearing up the thin metal of the sleeve. You estimate about how far you need the drill to go into the tooth by holding the drill bit against the side of the face, and your skin staples will help with this. Seat the drill bit firmly in the center of the occlusal surface of the tooth and drill. This part usually requires 2 people, one to operate the drill and one to monitor the progress while looking in the horse's mouth. You can take a radiograph with the drill bit in the tooth to see how far you've gone. Once you have drilled a hole in the tooth, you will need to tap the hole. This creates the thread so that you can then seat your screw. The tap tool is inserted through the trocar sleeve and into the hole. It's then manually twisted. After every 3 to 5 clockwise turns, you should take a counterclockwise turn to help pull out tooth debris. After tapping the hole, you insert the screw and seat it firmly into the tooth. You then use a slotted hammer to tap firmly down on the disc at the end of the tool. This will draw the tooth out of the alveolus. As the tooth begins to come out, bloody foam will appear all around it. This is a really good sign. It means the tooth is about to come out. Once the entire tooth is out, the screw can be removed and you can take the tooth out orally. You should inspect the tooth to make sure it's not fractured or does not appear to be missing any roots. You should also take a post-op radiograph to look for root fragments. You can see here's where 209 has been removed. It's not necessary to close the buccal mucosa. All you need is 1 or 2 skin sutures or staples to close your skin incision. The alveolar socket should be flushed. It can be packed with a dental impression material, such as polyvinyl siloxane, if you desire, or you can leave it open. Antibiotics and NSAIDs can be given on a case-by-case basis. Possible complications during the procedure include lacerating an important structure during sleeve placement, laceration of the palatine artery, which runs very close to the palatal surface of the maxillary teeth, fragmenting a tooth, and also possibly leaving a piece of fractured root or alveolus that becomes a sequestrum. There's also a slight risk of facial nerve paralysis, loss of sensation to the tongue, and pupil dilation associated with the nerve blocks. Luckily, those effects are usually transient. Wound infection and oral antral fistulas are also possible postoperatively. Luckily, most of these complications can be avoided with careful patient preparation and good surgical technique. So my take-home points are that the gold standard of equine cheek tooth extraction is intraoral extraction in a standing sedated patient. However, in some cases, this is not possible. In those cases, a transbuccal approach to cheek tooth extraction is an excellent method for removing cheek teeth that cannot be extracted intraorally, and it can be performed by any practitioner in the field. And importantly, the key to successful extraction is proper patient preparation and sufficient loosening of the tooth prior to extraction. These are my references. And I would like to acknowledge God and my incredibly supportive family, both 2- and 4-legged. And while the 2-legged ones couldn't be here today, Woo, my dog, is here. And then also my excellent advisor, Dr. Fred Caldwell, and all of my vet school friends and study partners, 2- and 4-legged, and my great first equine rotation, which is equine critical care, and then my patients who were named Bridger, Sienna, and Ellie. And then to the class of 2016, I can't say the traditional we're almost done, but I can say that a week ago, this was us, and now this is us. So we should all be feeling like this. And are there any questions?